Good morning. This is Ray Walker with the Medicare Assistance Program at the Oklahoma Insurance Department. We're so glad you could join us for this second webinar in our series on Medicare. This is the second one, as I said before. I wanted to make sure that you're also aware that we've got several more that are coming up. Next week, we've got Carmen Irwin from CMS who's going to be talking about Medicare Part B. So I would encourage you, if you haven't registered for the other webinars, go ahead and take the time to go online, go to our website at oid.ok.gov and register for any of the webinars that are coming up. Any of those that interest you, register for all of them. We would love to have you participate in all of these. Our webinar today is specific on Medicare Part D. That's the prescription drug plans. There's been some changes that are happening in Oklahoma. You know, we started out last year with 30 plans. We're down to 23 Part D plans. So that means that some people are definitely going to have to make a change this year. So we're very glad to have Melissa Scarborough from CMS with us. Melissa graduated from Texas A&M University with a master's in public health with emphasis in community health and management, in addition to her certification as a health education specialist. She completed a 2-year intensive training program as a presidential management fellow. She's been at CMS for 20 years now and currently works in the Division of Local Engagement and Administration in the Dallas Regional Office. So Melissa, so glad you could be with us today, and we're looking forward to hearing from you.
Well, thank you so much for having me. Welcome all. You know, you never know who you're going to get to talk to, and we're so thankful to have this virtual environment so that we have a chance to reach out to all of you. But unfortunately, it's just not the same as being live and in person. So sometimes I might say little things, try to get your attention, and just know you're out there. And so I really appreciate you all coming and listening today. And since this is recorded, you know, I would love to know that you all are sharing this with your friends, with your groups that you're a part of. For those who need to know, you know, what's going on as Medicare open enrollment period comes up. Of course, that's what we'll be talking a lot about today. We'll be getting into the nitty-gritty of prescription drug coverage. That's one of the big things for folks that they need to look at when they're going through the annual open enrollment period, to see if their needs have changed, to see if what's being offered has changed, and that type of thing. So what we're going to do today is just kind of get into what is intended with the prescription drug coverage, maybe what are some other things around in the Medicare program that might impact that, and just help you have a better understanding of that. And so I'll reference a few things that you may already know, but I'm going to try to reiterate some things that some of our newbies may not be aware of as well. So I'm going to go ahead and stop my video so that you have a good strong signal and my voice keeps up with my with my PowerPoint presentation that I'm going to present. And then at the end, we'll come back on and answer questions and see what other needs you might have and go from there. So with that, without any further ado, let me go ahead and share my screen. And so again, we're going to talk about Medicare prescription drug coverage today. And let me just move my little things out of the way. All right. So we have, I'm not gonna lie, we have a lot of information in our presentations for everyone with Medicare. There are things here that we may not go over in depth just because of time and because some things you're really not going to understand or want to know until you're in that situation and you find yourself needing some more details. So for that reason, all of our presentations are public and we're happy to share those with you or share the link for these presentations if you want to take a look. We have great notes down in the notes sections of these. And so I'm just going to kind of go through and give a bit of an overview and just kind of make sure you understand the program in general and then what we're talking about falls within the program. We'll talk a little bit about what it takes to be eligible and some of those enrollment requirements, things you need to consider when choosing plans or doing your annual checkup, so to speak, with your plans and your coverage during open enrollment period. Talk about what those costs are, and then explain a few more pieces about your rights and that appeals process. We won't really have a lot of time to get into the appeals process. We actually have an entire other presentation just to cover what all you would need to know. But typically, unless you find yourself in that situation, those are details that are best saved for another time. We just want to make sure you know that it's there and you have these basic rights in case you ever need. So getting started, just kind of understanding where does this fit in with drug coverage versus where something might be covered in a different part of Medicare. So if you're familiar with Medicare, we kind of have it divided into parts. So Part A is anything inpatient, basically. It's our inpatient hospital, inpatient skilled nursing services, inpatient rehab services, maybe inpatient psychiatric services, hospice. All those types of things are Part A. Part B is what we typically use for our outpatient, our medical doctor services, labs, durable medical equipment, things like that. Now, typically, just so you know, in case you're not aware, your Part A, that is what you work and put into the system, or a spouse has worked, or if you're disabled, a parent has worked and worked at least those kind of what we used to talk about as 10 years of work records, and they don't have to all be together. Now they figure it at Social Security a little bit differently because we have so many folks that, you know, they may work during certain parts of the year more than others, depending on their business and things like that. So that's a whole other presentation again, but just understand that's what we're talking about, that Medicare Part A. Part B is the one that you're paying that $148 a month, or we just got the new numbers today, but they do be aware they will be updated soon in our presentations, but that has not happened yet. But Part B is that insurance that you have taken out of Social Security or you pay separately. And then Part C, if you've heard of us talk about Part C, that's the one that came next in the development of Medicare. And that's that choice of having these health plans like you have in the private sector, whether they're HMOs, PPOs, whatever that may be. There's a choice there. And we'll talk about those a little bit as we go, because those also will wrap up and kind of package up together the Medicare Part D. D is for drugs. And it just so happened to work out really well that our prescription drug coverage was our next thing that we added to the Medicare program, so that it ended up with being D in the alphabet. And you would think we had that planned all along. Maybe someone up above did, but so it turns out that that's our prescription drug coverage. And so we'll get into a little bit more about that, but just understanding that everything, anytime we have anything covered, it's going to depend on a medical necessity, determining where it's given. That healthcare setting might determine which part covers it, what it's being used for, any legal statutes and other drug requirements will all help decide, kind of which area covers a particular drugs. So again, I'm not going to spend a whole lot of time on each slide. Like I said, Part A, generally everything inpatient and hospice, those items for your care there. Part B, generally those things that are given at the doctor's office. The things used during end-stage renal disease treatment, things that are covered with your durable medical equipment, those infusion pumps and things, some of the special anti-cancer drugs and things that you might take offsite as well. It also covers our immunizations. So again, that's Part B. Those are things that everyone in Medicare has. They might have it bundled up with a Medicare Advantage plan, but these are things generally covered by Part B. the self-administered drugs in the hospital. Now, these are a little tricky, and you may have heard about people getting a separate bill for some of their individual drugs that they had that didn't have anything to do with why they were in the hospital, but they knew they had to keep taking them. That was part of their existing drug regimen before whatever happened that took them into the hospital. So those are times that you might see, if this ever happens to you, you might see that there's some of these additional drugs that weren't covered that you might be able to submit for coverage with your prescription drug plan, separate of that Part B, self-administered drugs in the hospital setting as well. So just to be aware, if you ever find yourself in that situation with a separate bill, that there's a possibility there as well. So it did not save my choices, but my presentation. And so there are a few extra slides in here that we're going to see that I'm going to run through, but just to be aware, let's go ahead and pretend like you can participate and just say it out loud to yourself on these questions. Which part of Medicare pays for drugs in the hospice care setting? Now, this is the ones that are simply for control and pain relief only. That's correct, Part A, hospital insurance. So let's talk a little bit about how Medicare drug plans work. They're all, you're probably familiar hearing these very well-known companies. They offer Medicare Part D plans. They might offer a Medicare Advantage plan. They might offer even a Medigap supplement plan. And that's where it can be kind of tricky, because sometimes it can be hard to remember, wait, what are we talking about here? So if ever you're working with someone, just kind of make sure you really know, okay, what are we talking about? Just because someone says one of these famous names, it doesn't actually tell you any more about what the coverage is. Maybe understand the difference there. Again, available to anyone in Medicare. They have various options. There are some exceptions to that with some folks with some particular chronic diseases and things that we may have some special plans for. But in general, you get your coverage through Part D or combined with your Medicare Advantage plan as well. So the basic drug cost, now keep in mind, we just had a little bit of an increase that came out today with those cost of living adjustments that were announced. It's about a 5% increase, I believe. And so you'll see these numbers updated soon. In 2021, basically, the numbers we're looking at here, you start with your monthly premium. Now, that's the same with just about any kind of insurance that you're going to deal with. The thing about it is, a lot of times, once we're in retirement and on Medicare or what have you, we want, there are times some folks want very consistent payments over the 12 months. And some, they're like, well, I don't have a whole lot of cost. I can handle a deductible if something comes up. So what you'll find is you might have those monthly premiums a little bit higher with a real low deductible, or you might find monthly premiums quite a bit lower with maybe a higher annual deductible. The next thing that comes into play are those co-payments or co-insurance. There is a difference between those two. Co-payments, there's some plans that use co-payments where it's going to be exactly this dollar amount for this type of drug. Whereas others, it might be a co-insurance where it's a 25% or of a particular negotiated drug cost, not just anything they might place on the drug saying, okay, this is what we're going to charge you. It's what the negotiated Medicare rate for that drug is. Once you get through spending on those deductibles, those co-payments or co-insurance, plus what the plan is paying for you, in combined, you get $4,130 worth of drugs. That's when you hit what used to be known as our coverage gap, but it's about evened out now thanks to the Affordable Care Act. That's one of the things that happened where it helped take away that that donut hole, as if some of you long timers may have heard about in the past. And we don't really have that anymore. So we just keep on with no more than 25% of the drug costs until once everything adds up to that 65.50, that's for 2021, the catastrophic coverage limit. And if someone hits that, then they pay no more than 5% for the remainder of the year. And we have some folks that with their cancer treatments and stuff, they're hitting that in the first month. So so for some, they may never hit that through the whole year, and that's fine. And for others, they're hitting it right at the beginning, and it is just a huge help for them. So just understand this is what a basic plan kind of looks like. Those are the numbers it looks like. Your drug coverage can be more generous than that, but nothing can be less generous than this basic plan. So here's a little example with Miss Smith, and it brings up something that I want to kind of point out here that was part of a change with Medicare when drug coverage very first came out. Notice that she got her drug plan. It starts on January 1st. Everyone knows that during open enrollment period, when you choose a new plan, it's going to start January 1st. She doesn't get any extra help, which is our subsidy to help. It's on a sliding scale for those who may not quite make enough to get all their prescriptions and things. We'll talk more about that later. And she uses a drug plan membership card when she buys prescriptions as well. So there are some prescription companies that may have some discount cards and things, and we'll talk a little bit about that. She also pays her monthly premium throughout the year. So in the very beginning of this example, looking at a fairly basic benefit, she has to pay the first $445. That's the deductible for her plan that she picked out. So that's what she does right off the bat. Then she's still in that initial coverage phase, and she's paying basically 25% of the cost of that drug, and the plan picks up the other 75% of the negotiated cost for that drug. That continues until they hit that 4130, and we know that'll change just a little bit for 2022. That's when they hit what we used to call that coverage gap or donut hole, but we really don't see a huge donut hole there anymore. You'll see that basically she's still not paying any more than 25% there, and that's at the point once she hits 65.50 with what she's paying, what the retailer discount payment company made toward her drugs as well when she used that little drug card, and what the plan pays, all of it added together. When it hits that 65.50, that's when she's going to hit her catastrophic coverage and pay no more than that 5% for the remainder of the year. Now, of course, that resets and starts over the next January 1st. One thing that we have with Part B, our outpatient doctor emergency room coverage, is IRMA. And for Part D, we have IRMA as well. It's that little rule that I always say, my mom always said, fair is not always equal. And this is a great example of that. IRMA is something that was put into place in order to help protect the Medicare Trust Fund, because, you know, we did used to hear a whole lot about it going to go bankrupt at some point as more people were aging in. This is one of those things that was put into place to help protect that. And basically, if you're blessed enough to be making in a joint tax return more than $176,000 a year in retirement, then yes, you're going to pay just a little bit per month more added to your monthly premiums. So you can see that there. and we used to say this only impacted about 3% of our Medicare beneficiaries, but now it's closer to between 5 and 10. But it's much less than 10, but closer to 5. And it is it's great that we have folks that are more blessed in retirement these years that have been planning, but for the most part, this is not going to impact anyone. I do want to point out this little red line at the bottom where you see that married but filing separate tax returns. Sometimes folks are married and for financial reasons, for business reasons, etc., they'll go ahead and file separately. Do understand that if that were to happen and they're truly married, they live together at all at some point during the year. Now, if it's someone that left 20 years ago and you have no idea where they are and haven't seen them since, but technically you're still married, that does not count. And you can document that to make sure that you're not put in this category. But basically what happens when you're married and choosing to file separately, then you lose the incremental levels of increase there as your income goes up. Basically, if you make more than 88,000, you jump all the way down to those that were making 165 to 500,000, and you get that $70.70 tacked on. Again, it's going to be a tiny bit different for 2022. So just remember that, and it goes through 412,000, and then anyone 412,000 and above married filing separately, you've got that very high level that someone that's just filing an individual tax return wouldn't hit until they were at 500,000 income. So just recall that's each added monthly to the monthly premiums. So when making decisions, it's going to impact not only Part D, but also, as I remind you, Part B. That's a different presentation, but it does impact Part B as well. So just something to consider. So like I said, we're getting rid of that coverage gap really quickly. We're just about there where we can really say there really isn't a donut hole anymore. The cost for most people, it's never going to go above 25% during that period. If there is a reason why someone might need a discount or some help with drug costs, then we do have information on how to file an appeal. We'll talk a little bit more about that in a moment. So one definition you might hear about at the pharmacy counter is TROOP, the true out-of-pocket expenses, payments that you have made for the drugs. And that's something that the drug company will track. You'll get your explanation of benefits, kind of keeping that added up for you. And that continues even if you switch plans during the year. And we'll talk about ways you might have the opportunity to do that. One of the big things now that's this last bullet point on here, you may not know this, but there was a reason for the longest. You would just go to the pharmacy and they might tell you, hey, this is what we have, and this is how much it's going to cost you. And you're like, are you serious? Okay, this has happened to me before. I'm just telling you, I'm like flabbergasted. I can't pay that for a prescription. I mean, I had one that was a basic prescription that was supposedly covered by my plan, but they were going to charge me $800 for it for 1 month's supply. And they just said, yep, that's what it is. And they wouldn't say anything else. Well, that was because there used to be a gag clause, and we'll talk more about that, where they couldn't actually tell you, hey, if you'll just do it without your insurance, it'll only cost you $50. Things like that. So now, as part of the new laws, the pharmacists have to tell you if there's a better price that's available without going through your plan. So that's a huge thing for folks to be at the pharmacy counter trying to figure out what to do. And the pharmacist, who knows good and well what's going on, is able to tell you and explain that. So here is just kind of a quick list of things that are considered going toward that true out-of-pocket. That's important because, you know, as it's added up, if you're getting close to catastrophic level, you want everything that's being paid to add into that. And therefore, a little bit when we very first started prescription drug coverage, there were a number of things that's like, I don't think so. That's not going to count. That doesn't count. Well, now you see they've gotten much better. Any of these things going toward your drugs that you're getting for you to take are being added up into that true out-of-pocket costs that you're using to get to that catastrophic level. Here are some important things just to understand that don't count toward true, things that are not covered by the plan. So if you go in and get a non-prescription, just over-the-counter vitamin, it doesn't matter even if it's part of step therapy before you get that prescription level. Those cannot be counted toward your true out-of-pocket expenses. Those that are paid by other insurance or a government-funded program, those types of things, not that are where they reimburse you and you get your money back. That doesn't go toward what it says that you paid and are out of pocket. So things like that. So what are our rules for drug coverage? Basically, for these plans, they have to cover both our brand name and generic. They have to be FDA approved and used and sold in the U.S., and it has to be for the medically accepted indication. Some of these things, we know there are trials to use a drug that was created for one reason, for something totally different. But as long as those are in trials and they have not been approved for that particular treatment yet, then Medicare cannot cover it. That also includes our drugs, biologicals, and supplies associated with injection of insulin as well. And another thing to keep in mind, each of the plans, we'll talk about it more, have to cover drugs in every category. When we very first started Medicare prescription drug coverage, we had some plans that weren't covering certain drugs that only folks who were really, really sick needed. And therefore, that eliminated them from having really sick, costly patients with their drug plan. And so that's huge. They were kind of self-selecting the healthiest people so that they would do really well in business. And sure, if that was allowed, that would be great. And so that is no longer allowed. They tightened up all of the rules in implementing the prescription drug coverage. And now there are some basic categories that every drug plan has to cover. Coverage and rules do vary by plan as far as exactly which drug it will be and things of that nature, but there are still some basic categories that have to be maintained. So here are the ones that I mentioned, these protected classes that we realize up front, oh my goodness, that's not going to work. Everyone has to cover all the cancer drugs. One might not work for another. So it's a protected class where if someone is diagnosed with cancer, they should be able to have access to whichever one might be best for them. Same with HIV drugs, antidepressants, antipsychotics, anticonvulsants, and our immunosuppressants. The same goes for all the commercially available vaccines, and that does include now our COVID vaccine, as well as the flu shot and things of that nature. Things that are excluded by the drug coverage are things that are strictly for weight loss or weight gain, strictly for anorexia, erectile dysfunction, fertility drugs, other Botox, things like that, when it's given strictly for cosmetic purposes, cold and cough medicine over the counter, like I said, vitamins, other over the counter drugs and things. Those cannot be covered because our trust fund is only so big, and those are things that are going to have to come out of pocket. Or there are some Medicare Advantage plans that might have, say, we're going to cover some of these over-the-counter drugs in order to help keep our population healthier. They might have some more flexibilities where they have some tack-on plans that you can buy and that might cover other things. But in general, Medicare Part D coverage and Medicare Advantage with Part D, these are things that are excluded from the plan. As far as access, these are the things that you hear about. Okay, I know they cover it, but how hard is it going to be for me to get that prescription? And so it's something you really want to be aware of when you're thinking, if you're down to 2 plans and you find out, oh, wait, I have to have this prescription. This one, when I very first sign up, it's going to make me start over and try to make me go through step therapy to work my way back up to it. And I've, worked years to get to this place, and I do not want any changes with my prescription. You're probably going to choose the plan that makes it much easier just to access without any of these particular issues to deal with. Just understanding what these definitions are for these particular keywords that you're going to see when comparing drug plans. The formulary, that means basically what drugs, when we know they have to have at least a couple of drugs from each class, et cetera, which ones are they actually going to cover on this plan? They actually have a list. This is the formulary, which oftentimes they say, you know what, if you want to be certain the first time, you want to print off this formulary and carry it with you to your doctor so they prescribe you something off the formulary for the first time. That's something that very proactive folks might choose to do. Prior authorization, that means that the prescriber is going to have to contact the plan and show that it's medically necessary before the drug will be covered. So that is something that's going to involve some involvement with your doctor and medical records, et cetera. So that might prove to be a hindrance in some cases. There's some cases where all the drugs, pretty much not all the drugs, the drug for a particular type of drug for all the plans, they might require some sort of prior authorization. We'll talk a little bit about opioids and things there. There's some things that are done strictly for the safety of that individual. Step therapy, where they require you to do try a different drug that may be less expensive first and then move up into progression. So you're not just trying the most expensive one that's the most popular you heard most about with the commercial or whatever first. So that's what step therapy is. And then quantity limits. There are some that are going to be limited, whether it's due to safety or cost. And that's where, again, these drug plans are still important to make sure you have access to what's medically necessary. And so if one of these things were being done to kind of watch cost with that drug plan, the prescriber may help you with an exception to get what's medically necessary for the individual. It won't apply to everyone in that plan. It'll just apply to that individual for the rest of that one calendar year. But there are some ways around that. Also, different tiers. So it may be something that the prescription drug plan covers, but they'll have different tiers in payments. We actually have one new extra specialty tier where they're very high cost, over $800, where you're not going to have as many flexibilities. But basically, our first three, most generics are going to be in the lowest co-payment, co-insurance tier 1. And then you move up in your cost structure to kind of mid-range co-payment for those preferred and brand name drugs. Then you have the highest or higher co-payment at the tier level 3, where these are not the preferred ones. These are brand name. They're pretty expensive, but usually they're not the most prescribed. But now we also have something that's very unique, specialty drugs in that highest co-payment structure. These are some of the ones that it just costs too much to have too much flexibility around them. I'm trying to get them out maybe when they've first been released, etc. Now, I will say one of the things that happens sometimes is, say you've signed up with a plan and they said this is what it's going to cost you per month. But then in the middle of the year, they come up with a generic and release a generic. And so now your what you're paying, they send you a notice and say, hey, this is going to go up in cost because now there's a generic available. you can actually request a price exception where you say, no, this is what I signed up for. This is what I can afford. Whoopsie. And this is what I want to keep paying for the remainder of the year. And you can actually do that. Or you say, you know what, this one that you've put it up into the tier 3, I really need it to be tier 2. This is a new drug for me. I can't afford it in this other. And here's the reason why. And my doctor has joined in, said it's medically necessary. Can you please put it at the tier 2 level for me so it's not quite so expensive just for me because I used my rights and I asked. So you have those rights. There are some now, though, that are at the very highest level in this new specialty tier where you cannot get that reduced. You cannot even file an exception and ask to have it lowered to a lower tier so you don't have to pay as much. So that's one of the things that are new just because of the expense. Do recognize that, again, like I said, there can be changes in the middle of the year, whether it be to where that drug is going to fall in various classes, categories. There are things that can happen during the year. The plans, notice this, usually notify you 30 days before the changes take place so that you're aware when you go in and you can get your refill, etc. Notice that it says usually. Should and always do in real life are not the same thing. So just be aware of that. That's where you really want to also remember there are times you need to make sure you know what your insurance plan's logo looks like, and check the mail and make sure you don't accidentally throw something away in junk mail and realize, oh, that was my 30-day notice. They just mailed me to let me know. There are opportunities there to ask for an exception if they're trying to change you to a different drug or a generic that's come out or what have you, because your doctor knows what's medically necessary for you and can provide that documentation. You may have already tried it years ago, etc. They're able to help you get that information turned in, and the plans have to take a look at that, and you still will have appeal rights and things with those determinations. And then there are times, just be aware, if something has happened and we've determined a drug is unsafe, it can be taken off the market, and there's no, hey, you get a refill or anything. That has happened. I believe it was with a heart drug a few years back, and a number of other things. But if something suddenly they realize people are really in danger by even being exposed to this drug, they can take that off, no questions asked, and go from there. A few others, just these again, a lot related to the brand name and the prices for that when you have the generics become available, or working with those different cost structures and some of the step therapies as well. In general, if it's happening to a large class or brand name or what have you, it does need to notify all plan members and not just the ones or those that are getting ready to enroll during open enrollment, not just those who are currently taking that prescription. Now, this is something that happened a few years back. We haven't talked a whole lot about opioids and some of the things that were going on with misuse there or overprescribing there since the COVID public health emergency. But one thing we know is that this has definitely not disappeared as folks have been kind of tucked away in their homes during this time. It actually is something that's continued to be a concern, and so do be aware that we do have some things in place to help detect unsafe use of opioids and to help protect folks from that. If we find out that there are multiple pharmacies filling these. We have these new drug management programs that will help, detect that. If that's the case, there may be some limit placed on what you're able to get. A letter is sent out, and it does show how to get the go through the appeals process, especially if you think that it's a mistake. But just because you think it's a mistake doesn't mean that it's not going to go into effect. If the drug management program detects this, and you get that letter, you still have to go through the appeal process to make sure that's cleared up. Also, just understanding that there are some safety reviews that are going to pop up at the pharmacy for some potentially unsafe amounts, or if it's new use, and notice there might even be some times where the pharmacist is not able to fill the prescription, and we'll let you know that why and what your prescriber might need to do to get that coverage determination changed there for that individual. Now, as far as all Medicare plans, there, of course, did not turn off my phone, and those spam callers are terrible. Hopefully that didn't mess up our recording too much any more than my interjecting did. But the plans, just looking at the preclusion list, there are some things that we found are not quite above board. Maybe currently revoked those individuals and entities from the Medicare program. And if that is the case, that's another thing that has been put into place to be able to identify that. And if that prescribing provider is on our preclusion list, the pharmacy is not going to be able to fill that prescription. And that goes for whether it's Medicare Advantage plans or Part D prescribers as well. It's part of what they've done to ensure patient safety and help protect the trust fund from these fraudulent prescribers and providers. So there's just a little bit more about the preclusion list. We actually can go and look that up and see who's on it every month if you wanted to, and there's a link in that in those resources if you decided you wanted to check that out. But the health plans and Part D plans do have to watch that, remove those from their networks if they're part of their networks, and notify any beneficiaries, any of you guys who might have seen one of those or had a prescription that was written by one of those. They have to notify you as well. That notice, here's what we recommend. We know in real world, it doesn't always happen that way, but 60 days notice in advance before those claims are going to start being rejected because they were part of prescribed by someone on that preclusion list, etc. That gives them that 30 days kind of to review for the plans to review the list, notify Medicare enrollees, but then no later than 30 days from posting the list, they have to have folks excluded and folks notified with that additional 60 days for folks to be able to make changes and prepare for that change coming. So this was that gag clause I was talking about, and it really is huge. You know, the pharmacy sees these drugs come in and out every day. They watch these health plans. They know, kind of which ones folks are walking away with a smile and which ones folks are having to deal with all sorts of things. The gag clauses had prohibited a pharmacist, if they wanted to be one of the preferred pharmacies or work with that plan, they weren't allowed to talk about these things. And so that's no longer a legal practice. That can no longer be part of their contract. Pharmacies are able to disclose the difference between a negotiated price and maybe a lower price that's available and paying by cash or just without health insurance at all. And that went into effect in 2020. So huge thing. And if they did decide to choose to pay cash and get it less expensive there at the pharmacy, they can still submit that to the plan to be included in that troop counting, because it still should have been a covered drug. But they found, if the plan was going to charge them more that you could just buy it, outright, then someone had the right to know that and still have it count toward what they were paying. It was still their prescription. Medication therapy management, again, that's one of those things that happen that it is covered with your prescriptions. It gives the opportunity to allow someone to kind of talk about, is this really working, and various things. It is really put into place to help manage some of these medications that might not have been ideal. Chronic health conditions, where you're having multiple medications taken, really being able to catch those where there might be some indications of things kind of interacting with one another, etc. And being able to see, okay, here's what we're looking at for all the costs per year. I know I did a terrible job of explaining that, but given the time, just be aware we do have some programs that will do that and help catch things there as well. And all my little things. Your prescription, if it changes, like I said, there are things when you sign up for that plan, you kind of are going on some basic assumptions, but those prescriptions can change during the year. You make sure you take a look at your formulary, get an up-to-date one from your pharmacy, and the prescriber can choose a new one that will be covered by your plan, or help do that exception request, or get an exemption to get that covered, and maybe come up with some alternative. So on eligibility with Part D, you have to have A or B. As long as you're participating in Medicare in some other way, you can choose a standalone prescription drug plan. Now, if you decide you're going to have it all bundled up with a Medicare Advantage plan, you have to have both A and B, because that's what that Medicare Advantage does. It bundles all three, the A, B, and D together. And so just keep that in mind. I think we do have one cost plan for Oklahoma now, so that's a little interesting change, and y'all hear more about that during the Medicare Advantage presentation, I believe is next week or the week after. Again, this hasn't changed. We've always had this available to those who are lawfully present in the United States. It's not for those that are here unlawfully. It's not for those who don't live in the United States. And if you're incarcerated, we already pay for your health care with our tax dollars elsewhere. Of course, in order to get your drugs covered with your Part D plan, in most cases, and I'll show the one exception, you do have to actually be enrolled to get your drug covered. So that's important. Creditable drug coverage. If you already have drug coverage through your employer, through a retiree plan, through the VA, TRICARE, what have you, if you have other current drug coverage and it's creditable, then there's no need to pick a prescription drug plan, especially if it's already being subsidized by your employer and you're not having to pay as much for it. Then there would be no reason to even consider choosing and adding a separate standalone Medicare prescription drug coverage. The plans should be telling you every year, again, check your mail, make sure you know that your drug coverage is still creditable. And if at some point you lose that coverage, you would have a special enrollment period of 63 days in order to get signed up with a Medicare drug plan. If you're more than that 63 days without any creditable coverage, then you're probably going to look at some increased premiums throughout the year moving forward. Also, there's just some more examples of other ways you might have other coverage. Be really careful. Don't let someone accidentally talk about how they're going to save you money and get you signed up in a prescription drug plan, and you didn't even tell them, hey, I have retiree benefits and my family are still using that insurance. You know, I have younger family and they're still using that insurance. You don't want to do something that might cause you to get kicked off of your employer plan or retiree plan. So be real careful with that, and always work with your human resources, with your employer, or with the program that you have that coverage, just to be sure you know what you're dealing with. The initial enrollment period, it's just like with Part B. It's the month of your 65th birthday, then you have 3 months before it and 3 months after it. So 7 months total. Of course, if you have some other creditable coverage and you're going to keep that and sign up with Medicare later, don't worry, there's a special enrollment period for that. But initial enrollment period for Part D, it's the same 7-month period. Other enrollment periods coming up, October 15th through December 7th, that's Pearl Harbor Day. You want to make sure you've made your decisions by December 7th so they can take effect by January 1st. If something happened and someone completely forgot, oh my goodness, I was having such a great time, I forgot I turned 65, you would have to wait until that general enrollment period just to get the A or B signed up. And then during April through June, have the opportunity to choose a drug plan to go with that. But no, that's going to put you several months out with no coverage. And so something you really want to be careful of. That coverage wouldn't start till July 1st of that year. Again, Medicare Advantage open enrollment period is something that if you've bundled all this together as a Medicare Advantage plan, come January 10th, you're out there trying to use it and realize, oh no, this is not what I intended to do. This is not working with where I need to go. You get another open enrollment period to fix that. So as long as you're part of a Medicare Advantage plan, you can use that open enrollment period to switch to another Medicare Advantage with prescription drug plan, or you can go and say, I need to go back to original Medicare. I'm not going to do Medicare Advantage and just pick a prescription drug plan standalone. So those are things you can do just to make sure you have your coverage right once January 1st kicks in, and you have the flexibility to do that all the way through the 31st. And of course, if you're new to Medicare, you also have a 3-month period to do that as well. That way you still have time during that first 6 months of your guaranteed issue period for Medigap. If, say, you wanted to drop off of Medicare Advantage and choose a Medigap plan instead. There's probably a presentation coming up that will talk strictly about Medigaps, but do keep in mind Medigaps cost a little bit more. They don't cover extra things, just extra cost associated with regular Medicare covered services. And something you want to be aware of. Those don't change. They're federally mandated. They're standard by law, and it would take an act of Congress literally to change Medigap plans. Medicare Advantage can change every year. So that's why open enrollment period is so important. Special enrollment periods, they can happen for all sorts of reasons. It could be some sort of public health emergency. It could be a weather disaster. You could move. If you no longer live in the area, you can't have insurance there if it was only in one state and you've moved to an entirely different state, etc. Also, qualifying for other assistance can qualify you for a special enrollment period. I realize that we've gone over our 45 minutes of me just talking and talking, but I did want to point out just a couple of things for those dual eligibles. That means they have both Medicare and Medicaid. There are some special things to help those folks that we believe are particularly perhaps at risk, where we may help get them into a plan and give them some additional special enrollment periods. Anytime a plan is doing so well that it gets 5 stars, you can change into that plan any time of the year you want to. except open enrollment, your current your will already be using a enrollment period. So just keep in mind, do you have other health coverage? Is it creditable? Is it going to work with what I'm currently doing with Medicare? And also, like I said, don't forget, if you have other coverage that includes your family or members coverage, you be really careful. Usually if you sign up with one of these standalone plans, it will knock you out of that other, and you could lose coverage for your whole family. So be real careful about that type of thing. So we know we have open enrollment coming up, and that's what our state health insurance program is all about, with our benefits coordinators, counselors, helping you folks make those decisions, those one-on-one counseling for that. And certainly we have it available online and via phone as well. With that, I think we're not going to get into these others. I've spent plenty of time kind of going through this. I did want to remind you, be watching in the mail that evidence of coverage, the notice of change. If you're in a plan, you think you like your plan, it may still have some changes that are coming up that they have to notify you about, so that you're aware of that before open enrollment starts here on the 15th, right? Just a few days away. So just keep that in mind, pay close attention. It may be buried down in there, but there should be information about any changes that are going to be made. I'm not going to get into all the costs there, but do be aware that I mentioned Social Security earlier. This kind of rounds up our presentation on Social Security's website. They're the ones that have a couple of really important forms. If you're getting ready to retire and you're afraid you're going to be hit by IRMA, they have the Form 44 that will say, hey, this is a major life change. I want you to look at this proactively and see if maybe I shouldn't be charged IRMA. Make sure you calculate with my correct income, because IRMA, you do your taxes when, from the year's prior income. And then Social Security and CMS, we use that the following year after you've done your taxes to calculate what your IRMA might be, if there's someone that's going to have IRMA. So it's right at a 2-year lag before it catches up. And so if you're getting ready to retire, be aware there's a form on there to get that reevaluated. And the same happens if something major changes. Maybe there's a big change in income if you have your spouse pass away or what have you, and you want to make sure they proactively fix that and don't wait 2 years. And that Form 44. The other one is the extra help coverage. Anyone can help someone fill that out. We always say, if in doubt, fill it out. And it helps look at on a sliding scale if there's any way we can help with the drug costs, and whether they're part of a Medicare Advantage prescription drug plan or just a standalone prescription drug plan that can go to work to help folks on many different levels. And the great thing about it is, with the recent law, it did change that to where it will also screen for all of our other Medicare savings programs and then send that information over to the states. It won't actually determine if they're eligible, but it will help catch those folks and get that information sent to the states to look at further. So with that, I am going to stop sharing my screen. I know that I have just talked nonstop, accidentally for longer than I intended.
It's okay. I do have a couple of questions, though, that I want to run by you. One person has asked, can a pharmacy be dropped mid-year by a Part D drug insurance provider?
So yes, during the year, pharmacies and prescribers, those that are maybe working with those pharmacies and plans, that can change. And it is important that the individual look it up, find the next pharmacy that's in their area. That's one thing that I know our benefits coordinators, counselors can help look at participating pharmacies. Be aware too that there's preferred and non-preferred pharmacies even within the network. And that's something the plan finder will show you, hey, these are both participating pharmacies, but it will also show if you go to this one, it's only going to cost you $5. If you go to this one, it's going to cost you $10, even though they're both in network. So just understanding that they can have pharmacies switch from preferred to non-preferred and things like that within the year too.
Okay, next question. You mentioned about how people may have multiple insurance coverages. They may have a Part D plan, they may have VA benefits, they may have all sorts of stuff. So how does a person figure out what's their primary coverage and what's secondary and what pays? I think some people have too much insurance. So what should those people do?
Well, and that's another good reason to talk to one of our trusted benefits counselors because, sometimes it can be confusing, especially if you find yourself in a situation where you might even be a little overinsured. Sometimes people take out extra insurance just to make sure they're covered, but they don't actually work together. Medicare has a contractor that does coordination of benefits that looks at all of that very closely and will sort that out. Typically, if you're still working, Medicare is just about never going to pay if you've got employer coverage. So yes, it's great. You can go ahead and take out your Medicare Part A, but there's no reason to take out Part B as well while you're still working. And it could even cause you some problems with your employer coverage or even retiree coverage. So there's things to watch for there. However, we know that for things that do not coordinate, say Medicare and benefits you get only when you go down to the VA center, that is a time that some people may choose to have both because they want to be able to get their services when they're not around a VA center, when they're out traveling, going to see family, etc., or simply they are not wanting to wait in line as long and they're able to do both. And so that's one of the things our counselors are really good at helping sort out. There are situations if you work for a real small employer, then Medicare is going to pay first, and it's real important to have your Medicare benefits straight as well. So yes, it can be a little bit confusing, but that's what we're here for. There are some very specific rules, and we even have a presentation strictly on coordination of benefits too. If you're ever interested, we're happy to help go through and do that because it can get kind of complicated, but that's what our counselors are here and able to assist with as well.
Okay, one last question. And this one actually came up in the Q&A, but I wanted to bring it up in case people didn't notice it, was the question about vaccines. And this comes up quite a bit. This actually happened to my mom this year, so I had a very stern phone call. She went to get her shingles vaccine and went to the pharmacy and stuff, and she was flabbergasted at what she had to pay. So we had the conversation about how all the commercially available vaccines are covered by Part D, except for the flu vaccine, the pneumonia vaccine, and the COVID vaccine. Those are all under Part B as in boy.
Right.
But the shingles vaccine, she got hit with a pretty big dollar amount, and that was because she had not met her deductible.
Yeah, very important. And what you mentioned is also important when thinking about some of our other preventive services. That's one reason some of our other preventive services, we've actually said you don't have to meet the deductible just to encourage folks to go ahead and get them. We were finding that we have a long list of preventive services now that folks aren't getting because, or the really early detection screening services as well, they're not getting because they were worried about having to meet a deductible to begin with. And so many of those you do not have to most any of those preventive services, as long as you're not getting anything else done while you're there getting that taken care of, you shouldn't have a cost share there. But you're right, it is something to be aware of. Just that can kind of shock you, but it's not because of the vaccine itself, and that shouldn't happen with COVID either. That's a kind of its own world, so to speak.
Yeah, okay. All right, well, thank you so much, Melissa, for joining us today. That was a lot of information, and we appreciate you taking the time to join us. Thank you, everybody who joined us for this webinar. Wanted to remind you, we have another webinar coming up next week. Carmen Irwin from CMS is going to be here talking about Part B. And then the following week on October 27th, Angela Kane who works in the same office with Melissa, is going to be talking about Medicare Advantage plans. So if you're interested in signing up for those, please go to our website, oid.ok.gov. We would be happy to help to get you signed up for those. Also, you can call our office if you have any questions about Medicare. It is coming up on open enrollment period. Our phone number is 1-800-763-2828. We have counselors that answer that phone 24 hours a day, 7 days a week. We really want people to pay attention. You know, the information that Melissa was sharing about how much money you can save by being on the right Part D drug plan for you is so critical. So please, you know, give us a chance to go over the information with you. Let's see if there's a plan that might work better for you. If you decide you don't want to change plans, that's your decision. We're not going to make you do anything. We just want you to know what's available out there so that you can make the best decision for yourself. So thank you again for joining us, and we look forward to seeing you next week. Have a good week.